Oropharynx cancer tidbits. Sites include the soft palate, the tonsils, the glossotonsillar sulcus, the uvula, the base of tongue, the vallecula, the postero and lateral pharyngeal wall, which extends from the soft palate down to the level of the vallecula. The borders, the superior border of the oral pharynx includes the soft palate. The inferior is the superior hyoid. Anteriorly is the oral tongue, circumvalent papilla, and posteriorly is the posterior pharyngeal wall, or C2 or C3. Referred pain, outer ear comes from the anterior tongue via the lingual nerve, going back through cranial nerve 5, through the foramen ovale to the auriculotemporal nerve. Again, this is the outer ear from the anterior tongue via the lingual nerve, traveling through cranial nerve 5, trigem, through the foramen ovale to the auriculotemporal nerve, which controls the outer ear. Referred pain in the middle ear is from the supraglottic larynx via the superior laryngeal nerve, which is cranial nerve 10 or the vagus nerve, going through the jugular foramen to Arnold's nerve. You remember this: middle ear, supraglottic larynx, Arnold's nerve, laryngeal. A for Arnold, LA for laryngeal. Inner ear is from the base of tongue via the glossopharyngeal cranial nerve 9 through the jugular foramen to Jacobson's nerve. Jacobson's is base of tongue. B, Jacobson's equals base of tongue. So again, outer ear, lingual nerve, anterior tongue, middle ear, supraglottic larynx, Arnold's nerve, laryngeal, inner ear, base of tongue, Jacobson's nerve. In service, we'll ask about Jacobson's with pharyngeal, lingual, and tonsillar branches causing otalgia in upper aerodigestive cancers. Other symptoms: trismus, pterygoid involvement. Hot potato voice is base of tongue involvement. Workup for oropharynx cancer. Additional workup: H&P with attention to dysphagia, odynophagia, trismus, otalgia, HPV history, smoking and tobacco use. You want a pan endoscopy with biopsy, labs, CBC, CMP, LFTs, CT and MRI or CT/MRI of the head and neck, CT chest, PET for stage 3 or 4, dental, audiology, speech and swallow, HPV testing, either P16, immunohistochemistry preferred, or HPV DNA. FISH, criteria for positive P16, IHC is greater than 75% of the cells, and 2+ or 3+ intensity level of staining. Staging for HPV positive cancers, it's much simpler. There's a 2 to 4 cutoff. T1 is less than or equal to 2 centimeters. T3 is 2.1 to 4 centimeters. T1 less than or equal to 2 centimeters. T2, 2.1 to 4 centimeters. T3, greater than 4 centimeters or lingual epiglottis. T4 is larynx, extrinsic muscles of the tongue, medial pterygoids, hard palate, mandible, or beyond. There is no T4A or T4B for HPV-mediated tumors. End staging clinically: N1 is ipsilateral nodes less than 6 centimeters. N2 is contralateral or bilateral nodes less than 6 centimeters. N3 is greater than 6 centimeter nodes. T1 to 2, N0 to 1 are stage 1 tumors. T3 or N2 tumors are stage 2. T4 or N3 are stage 3, and M1 are stage 4. Pathologic nodal staging for HPV-mediated: N1 is less than or equal to 4 nodes. N2 is greater than 4 nodes. P16 negative has the same T1 to T3, but T4A is invasion of the larynx, the extrinsic muscles of the tongue, the medial pterygoids, the hard palate, or the mandible. T4B is lateral pterygoids, pterygoid plates, the lateral nasopharynx, the skull base, and encasing the carotids. N1 for P16 negative is 1 lymph node less than 3 centimeters. And again, this is a clinical staging. So clinical N1 HPV negative, 1 lymph node less than 3 centimeters, ENE negative. N2A, 1 lymph node greater than 3 centimeters, less than or equal to 6 centimeters, ENE negative. N2B, multiple ipsilateral lymph nodes less than 6 centimeters, ENE negative. N2C, bilateral or contralateral lymph nodes less than 6 centimeters, ENE negative. N3A, greater than 6 centimeters, ENE negative. N3B, clinically extranodal extension positive. Stage grouping for HPV negative cancers: T1N0 is stage 1, T2N0 is stage 2, T3 or N1 is stage 3. T4A or N2 is stage 4A. T4B or N3 is stage 4B. M1 is stage 4C. Management, you can do either organ preservation with radiation or chemoradiation versus surgery plus adjuvant radiation or chemoradiation. No surgery, T4B would be unresectable or the patient is medically not a surgical candidate. Concurrent chemo if node positive or T3 or T4. The exception here is if a T1 with a single ipsilateral node, the 7th edition N1, you can treat with radiation only, or T2 with a single ipsilateral node, 7th edition N1, then concurrent chemo is category 2B per NCCN. If the patient gets surgery, then the indications for post-op radiation per the Peters study are PT3 or T4, multiple positive nodes, nodes greater than 3 centimeters, LVSI, PNI, extranodal extension, positive margins, and nodal disease in levels 4 or 5. Positive margins and extranodal extension are indications for chemo with adjuvant radiation. The intact setting, prefer concurrent chemo with cis 100 milligrams per meter squared every 3 weeks. The alternative is cetuximab, and after that, you can consider low-dose weekly cisplatin, or Cetux, again, is 400 milligrams per meter squared loading dose 1 week prior to radiation, then 250 milligrams per meter squared weekly. In the post-op setting, you prefer concurrent chemo as cis 100 milligrams per meter squared every 3 weeks. The alternative is lower dose weekly cisplatin. Don't use cetuximab in the post-op setting. The MOC-NC meta-analysis, concurrent chemo with radiation for intact oropharynx disease improves survival by 8%. Radiation alone, you can use 6 fractions per week, Dahanka style. Radiation paradigm for T1N0 or T2N0. Radiation alone, consider unilateral radiation. 70 and 2 gray per fraction gross, 59.5 to 63, 1.7 to 1.8. For high risk, 56 at 1.6 for low risk and 35 fractions. For T3N0, T1 to 2, N1, chemo RT, consider unilateral radiation for T1 to 2, N1. This is again everything in 35 fractions. 70 gray to gross, 59 to 63 high risk, 56 low risk. T4A, N2 gets chemo radiation. 70 to the gross, 59 to 63 high risk, 56 low risk, 35 fractions. T4B, N3 gets chemoradiation to the same thing. Surgery paradigm is more nuanced. T1, N0, T2, N0 gets surgery plus or minus neck dissection, plus or minus postoperative radiation for PT3 to T4, PN2, close margin LVI perineural invasion. Dose for the radiation afterwards would be 63 and 30 fractions if there's a close margin, 60 for post-op tissue, and 54 for the low risk. For T3, N0, T1 to 2, N1, you get surgery and neck dissection, commonly post-op RT or post-op chemo RT for positive margins or extracapsular extension. Dose here again is 63 gray if ECE, 60 for post-op, 54 low risk with a boost to 66 for positive margin, again 30 or 33 fractions. T4A, N2 gets surgery, neck dissection, always gets post-op radiation or post-op chemoradiation for positive margins or ECE. Again, 63 if positive ECE, 60 post-op, 54 low risk with a boost to 66 gray for a positive margin, and 30 to 33 fractions. Then T4B, N3 gets no surgery. Evidence here, Princess Margaret Hospital, O'Sullivan data, looks at contralateral neck failure rates of 3.5%, 2% for HPV positive and 3% for HPV negative. The basic conclusion from this is it's okay to treat the ipsilateral neck in this group, meaning a T1 to 2, N0 to 1 tonsillar cancer that's well lateralized with less than 1 centimeter invasion into the base of tongue or soft palate and greater than 1.5 centimeters from the midline. This trial confirmed a very low rate of contralateral neck failure even in N2B with ipsilateral radiation only. The ASTRO and ASCO 2017 guidelines say unilateral radiation should be delivered to well-lateralized T1 to 2 and 0 to 1 per the 7th edition tonsil cancers with no soft palate and no base of tongue involvement. Unilateral radiation may be offered with lateralized, meaning less than 1 centimeter soft palate extension, but no base of tongue involvement for T1 to T2 and 0 to N2A 7th edition. You do not de-intensify oropharynx treatment based on HPV status, as there is not enough evidence for that at the moment. The other trial you need to know is RTOG 0129 CRT. This is ANG, NEJM 2010, and Nguyen Tran 2014. It's looked at stage 3 to 4 squames of the oral cavity, oropharynx, hypopharynx, and larynx. Stratified by HPV status, HPV negative versus positive. Overall survival at 3 years for HPV negative is 60%. For HPV positive, it's 80%. In-service has approximately 25% difference in 3-year overall survival between the two. 82.4% HPV positive versus 57.1 HPV negative. Local regional recurrence at 3 years for negative tumors is 35%. For positive, it's 15%. RPA risk groups, low risk is P16 positive, less than 10 pack years, or P16 positive, greater than 10 pack years, N0 to N2A. Intermediate risk group is P16 positive and greater than 10 pack years, and N2B to 3 disease, or P16 negative and less than 10 pack years, and T2 to T3. High risk is P16 negative with greater than 10 pack years, or P16 negative with less than 10 pack years, and T4 disease. Techniques: treatment planning, definitive IMRT dose painting, 35 fractions. Gross is 70 and 2 gray per fraction. High risk for HPV positive says 59.4. For HPV negative says 63. Low risk gets 56. Volume construction per energy consensus. CTV 70 is the GTV primary with a 5 millimeter expansion, and GTV nodes with 5 millimeters expansion cropped from anatomic. CTV high risk is GTV P plus 1 centimeters, then crop. Make sure it includes adjacent at-risk areas. For the tonsil, this would be soft palate, base of tongue, glossotonsillar sulcus. Base of tongue, this would be glossotonsillar sulcus, follicula, pre-epiglottic space. For the soft palate, this would be the remaining soft palate, the superior aspect of the tonsillar pillars, the adjacent nasopharynx, superior to the pterygoid plates. For the pharyngeal wall, you do generous superior inferior margins in the areas of positive nodes. Make sure the GTV nodes plus 1 centimeter is included in the high-risk CTV, but you don't need to expand past the outer boundary of the muscle. For 2 high-risk nodes, CTV low-risk nodes, PTV is a 3 to 5 millimeter expansion. For post-op radiation, the interval from surgery to radiation should be less than 6 weeks. In 30 fractions, the bed and high-risk neck get 60 gray. Low-risk neck gets 54. Then you add a sequential boost to 66 gray for positive margins or ECE. First echelon nodes cover bilaterals 2 through 4. Nancy Lee adds retropharyngeal as a primary drainage for oropharynx, but Alex doesn't. If it's node positive, cover the ipsilateral nodes to the base of skull. Toxicity and follow-up. Overall survival at 2 years in local control for stage 1 is 75% overall survival, 90% local control. Stage 2, 60% 2-year overall survival, 80% local control. Stage 3, 55% 2-year overall survival, 70% local control. Stage 4, 30% 2-year overall survival, 50% local control. Overall survival at 3 years by risk group per ANG. Low risk is HPV positive, less than 10 pack-year smoking history, 93%. Intermediate is HPV positive, greater than 10 pack-year history, or HPV negative and less than 10 pack years and less than T4, 71% 3-year overall survival. High risk is HPV negative, greater than 10 pack-year history, or a T4 tumor, 46% 3-year overall survival. Long-term PEG tube dependency rate with chemoradiation is 15 to 20%. It's way lower with IMRT, basically down to about 5%. Xerostomia reduced with IMRT. This is analyzed at RTOG 0022. The rate of xerostomia is 55% at 6 months, 25% at 1 year, and 16% at 2 years. PARSPORT is a randomized controlled trial looking at IMRT versus 3D and its impact on xerostomia. 38% with IMRT versus 74% with 3D at 12 months. Follow-up for these patients, 1 week and then 1 month visits. PET CT at 3 months. If the neck node is hot and there's greater than 1 centimeter in size, dissect. If it's cold and less than 1 centimeter, OBS. If it's intermediate, then send to a surgeon for discussion.